Thank you very much. Thank you, Juliet. And I'd like to thank the organisers for giving me this opportunity to give you the medical oncologist's view. I hope to give you a flavour of the challenges and the exciting developments that are facing us, predominantly in advanced lung cancer. But as you know from the historical way that treatments have developed, very often systemic treatments that start off being tested in the battleground of systemic disease and metastatic disease will find their way into the adjuvant treatment of lung cancer and are used as part of our multimodality therapy of this disease. So it has certainly been quite a long road in the treatment of metastatic lung cancer, and in the last 4 decades we have seen significant improvements in therapy. However, we still have some major challenges, and in particular I want to highlight that unfortunately the majority of patients with lung cancer are still diagnosed with advanced disease. We still have challenges in terms of preserving the quality of life and improving the symptomatology of our patients. And also the survival gains from a lot of our treatments in the advanced setting are indeed modest. Not only that, but we also face other challenges. Lung cancer is still a very common disease, and it is still the most common cause of cancer-related death in many Western countries. And as you can see in the top graph there, it is a disease of predominantly older age, and therefore we have the challenges of the changes in physiology that take place as we get older. Although the mortality has dropped in males over the years, unfortunately in females is actually rising a bit as smoking becomes a bit more prevalent in the female population. And when we talk of prognosis in lung cancer, this is very much determined by the fact that the majority of patients are actually diagnosed with more advanced disease here to the right, where the prognosis is not good. I'll just point out that in fact the y-axis does not go up to 100%, it actually stops at 50. So even in the lower stages of disease, you are looking at a mortality rate of the order of 50%. So for many lung cancer patients, unfortunately, the frontier is still looks very bleak, a bit like this ghost town in the West. Well, what are the aims of our treatment when we treat lung cancer? Well, in early disease, we want to try and improve the cure rate. And how can we do that? I think we can do that by refining our staging tools so that we can select our treatments more appropriately. And I think we need more effective adjuvant treatments as well that will hopefully help us to rescue that 50% of patients who fail after surgical resection, even with the earliest stages. In advanced disease, the challenge is, can we actually control the disease for longer? Can we help cancer patients to live longer with their disease, but with a reasonable quality of life? And to achieve that, we need to control symptoms more effectively, so that we make lung cancer a chronic illness, and we need to minimize the adverse effects of our treatment. Well, those of you who've been in the field of lung cancer for the last couple of decades will know that the way that systemic treatments have developed has been very much, let's try this drug or this combination of drugs. Okay, let's treat all patients with non-small cell lung cancer, and this is the response rate, this is progression-free survival, etc. Well, we're now moving into a different era, and the next decade, I think, will probably be called the decade of personalized medicine in oncology, where we will no longer be giving, one-size-fits-all treatment, but actually we will be selecting patients based on a number of predictors, predominantly genetic predictors in the actual tumor, and these predictors will help us to select therapy for our patients. And this is what I understand by personalized medicine. It's basically an approach which will help us to maximize the chances of benefit for our patients by identifying biomarkers in the tumor that will allow us to direct specific therapies which will have a greater biological effect than the conventional agents that we currently use. And that will also help us to reduce the morbidity associated with these interventions through our better understanding of the biology of the disease. And I think we need to pursue outcomes which are clinically meaningful, and I'll explain what I mean with that in a moment, and that are really relevant to our patients. And I'll use this example of the signal transduction pathway because this has provided us with some very interesting targets over the last decade, and also some interesting drugs. As you know, the signal transduction pathway relies on a number of cell surface receptors, which when stimulated will trigger a cascade, if you like, which influences a number of parameters in the cancer cell, such as growth, cell division, angiogenesis, and also the ability to metastasize. And a number of agents have been developed which can block these various receptor tyrosine kinases here. And what cancer cells have learned to do is that through genetic mutation, they have learned to leave these receptors constantly switched on. Okay, in normal cells, they are used and then they're switched off. But in cancer cells, they're constitutively switched on all the time. And it's like leaving a light switch on, basically. And that drives the cancer cell, and it helps it to grow, to divide, and to metastasize, despite an increasing burden of genetic mutation and DNA damage. Okay, so if we're able to characterize cancer cells, for example, by their expression of, let's take the EGFR receptor, the epidermal growth factor receptor. Okay, and when we and we are able to target that genetic mutation by means of drugs such as erlotinib, for example, which is an EGFR inhibitor. But in the earlier studies that we did, and this was a study reported 10 years ago, okay, we didn't actually select our patients based on the expression of that receptor in their tumors. So we simply got erlotinib, and we did a trial where we treated all patients with adenocarcinoma of the lung. Okay, and not surprisingly, when you use such a targeted agent in a non-selected population, you get very modest activity. Okay, a response rate that is no better than conventional chemotherapy, and a difference in progression-free and overall survival, which is quite modest and no better than systemic treatment. Similarly, when we combined these agents with systemic chemotherapy in the first-line setting of advanced disease, it made no difference, actually, whether we used chemotherapy alone or whether we used different doses of gefitinib or Iressa, in this case, combined with chemotherapy. Not only that, but if we actually use a population of patients whose tumors do not express mutated EGFR, and we treat them with erlotinib versus docetaxel, which is a conventional cytotoxic agent, the patients who actually are treated with erlotinib, in fact, end up doing worse. Okay, so in order to get the benefit from these targeted agents, we've established proof of principle. We need to use them in tumors that overexpress these receptor tyrosine kinases or have mutated forms of these receptor tyrosine kinases. And here you can see a study of progression-free survival of erlotinib versus conventional chemotherapy in the first-line treatment of an enriched population, of a selected population of adenocarcinoma of the lung, where all the patients harbored an EGFR mutation. Okay, and there have been several studies, as you can see here, both European studies and also Asian studies, because there are population differences in the expression of EGFR. Okay, in Eastern populations, the incidence of mutated EGFR lung cancer is higher. Okay, in our population, the Western world, in the UK, it's probably about 5% of lung cancers. Unfortunately, we face issues with targeted therapies that we also faced with conventional chemotherapy, and one of the big ones is acquired resistance to our treatment. Okay, and with biological agents, with targeted agents, that does happen either because the receptor that you're trying to target develops a mutation which makes it resistant to the treatment. The drug cannot combine to the receptor and block it. Or because the tumor cell learns how to do without the receptor that you're blocking, and it will instead use other pathways to get round it. Okay, and once you have cancer cells that have developed that resistance, they will eventually take over your tumor. They will be selected out by the selection pressure imposed by your treatment, and your cancer now consists of resistant cells because you've eliminated all the sensitive ones. And it's actually quite frightening as research gives us more insight into how the genome of the cancer cell is a moving target. Okay, it does not stop And this is a study from a paper in kidney cancer, actually, but I've no reason to expect that the same does not happen in lung cancer, where basically the investigators took multiple biopsies from different areas within a primary renal cancer that was removed, okay, and also from different metastases. So that was the chest wall metastases, these were lung metastases. And what this diagram shows here, the gray squares are mutations, okay. These are mutations that were present in all the tumor samples. Okay, so they are present in the primary, as you can see here. They are early mutations which are carried through. Okay, but you then have shared primary mutations which are shared in different areas of the primary tumor. Okay, you have metastases which are shared, mutations which are shared in the metastases but are not present in the primary tumor. Okay. And then you have private mutations which are expressed differently in all the sites that are biopsied. Okay, so this tumor, as it grows and as it metastasizes, you have different parts of the tumor are actually developing different genetic profiles. Okay, and so if you're trying to target that tumor, it's actually you're trying to shoot at a moving target. Okay, and so it really throws into question the traditional way that we have been doing these tests. Okay, we get a biopsy, sometimes you help us as surgeons get a biopsy at the time of diagnosis or surgical resection, and at the moment we're basing all our genomic tests on that one tissue. Okay, but we now know that the tumor is actually changing its profile as we go along. So really, we've got to be biopsying that tumor at various steps. Okay, so we might biopsy at the start of treatment, but we then need to biopsy when it relapses. We then need to biopsy when it spreads somewhere else. We might need to biopsy after we've treated it with chemotherapy to see what's happened to that genome after we apply the selection pressures of chemotherapy. Okay, so you might think, well, this is obvious, but actually, up to now, I guess we've been very reluctant to rebiopsy tumor. One of the reasons is it's not always very accessible, especially if you're dealing with lung cancer. Okay, but which surgeon would operate on staging by imaging that was 6 to 12 months out of date, for example? And I think the same is going to be with our systemic treatments. Okay, and when you do start to tailor your treatment based on looking for specific mutations of acquired resistance, you can then bring in new drugs that specifically target those mutations. And this is an example here. Afatinib is another EGFR tyrosine kinase inhibitor. This is a population of patients who had all progressed on first-line erlotinib or gefitinib. Okay, so these have got acquired resistance, and yet we were able to see activity of this drug. As you can see, this is called the waterfall plot. Each bar is a patient, and you can see whether their tumors have increased in size, going up, or actually shrunk. Okay, and if they shrink by more than 30% by RECIST criteria, it qualifies as a partial response. Similarly, you may have come across crizotinib, which is a drug developed specifically to target this other mutation in ALK, which is another genetic mutation that's been found in a small number of lung cancers. And as you can see here, this drug has quite significant activity. Okay, if you look at each one is a patient, and the overwhelming majority of patients have either got stable disease or their tumors have actually shrunk significantly. Okay, and of course this is quite exciting because this is a much bigger effect than we have seen with conventional chemotherapy when we treat unselected populations. And I personally hope that that is the sort of drug and that's the sort of selection that we should be taking into the adjuvant setting. Okay, so that we see a far greater effect than we have seen with conventional chemotherapy in the adjuvant setting. So we know there's gold out there. How are we going to find it? And I think we really need to select our patients carefully. It's interesting that there is a growing body of evidence now on the presence of circulating tumor cells in the blood and circulating non-tumor DNA. Okay, and I think we need to see what that will mean in terms of selecting patients, for example, who on the face of radiological staging might appear to be potentially operable or irradiatable, but actually if they've got a significant burden of circulating tumor cells, maybe those are the patients who are actually going to fail the operation or fail the radical radiotherapy, and maybe we need to bring in these targeted therapies at an earlier stage. I think tumor sampling is going to be very important. I know it's very difficult to rebiopsy tumor nodules, but maybe we can rely on these liquid biopsies, as they're being called. Okay, so we can maybe take serial blood samples and be able to detect these circulating tumor cells, or indeed circulating tumor DNA, and we can use that in order to not only to predict who might relapse and who has a poor prognosis, but also we can look for changes as a result of treatment. I think part of the problem we've seen lately in clinical trials is that clinical trials have got much larger. Okay, so they cost a lot more, they involve a lot more patient, a lot more effort. But actually, the survival benefit from new drugs has tended to diminish over time. Okay, and often trials are reported as being positive because there's maybe a small improvement in one of the parameters, such as progression-free survival. It may not even be the primary endpoint of the trial, and therefore it is questionable. It is of questionable interpretation. Okay, so I think we need to design smaller studies, and we need to identify potential predictors of greater benefit so that we can get answers more quickly. Okay, this is the old way, if you like, of testing our drugs, but to test a drug from there to there, it can easily take 10 years, if not longer, and I think we need to devise more effective ways of looking for new agents. And so I think we need to move away from trials in specific tumors, okay? Because what we're learning is that a lot of these genetic mutations are actually present in different types of cancer. We can see mutations that are present in lung cancer, also present in breast cancer and bowel cancer. Okay, so in fact we're already seeing what are called basket studies being conducted, where the population going into that trial are actually of different types of cancer, but they all have the same genetic mutation that is being targeted. Okay, and I think we need to move genomics to the earlier stages of disease. And we need to do longitudinal studies whereby we have serial biopsies, as I've already said. This is a very interesting article which in fact gives a very, I think, forward-looking view of the direction that we need to go with increasing our knowledge of the genetics of cancer and compiling libraries of these genetic mutations in descending order of importance, if you like, as to how they influence tumor behavior and the outcome of treatment, and then using that information in order to develop drugs that specifically target them. And we're already moving in that direction. Okay, this is one trial which is in the process of set up in the United Kingdom, the Matrix study. And what the Matrix study will do, which is a study in non-small cell lung cancer, is that it will identify molecular cohorts of patients by looking for a set of genetic mutations in their tumor biopsies or resected tumor after relapse. And that will divide the study population into groups of patients, which will then be treated by drugs which target a specific genetic mutation. Okay, so we will actually have, in effect, multiple studies running in parallel. Okay. And we're already seeing that concept being taken into the adjuvant setting. This was a feasibility study reported last year in the Journal of Clinical Oncology, where patients who'd had their non-small cell lung cancer resected were randomized to either standard adjuvant chemotherapy with cisplatin plus another drug, or else in the experimental arm, the tumor was characterized for EGFR. If the tumor was EGFR mutated, those patients received adjuvant treatment with erlotinib. If the tumor was EGFR wild type, it was again characterized for this other gene, ERCC1, which is basically a gene involved in the repair of DNA, the repair of damage that cisplatin does to DNA. And in tumors which are ERCC1 positive, they are resistant to cisplatin, and therefore they weren't given adjuvant chemotherapy. They were simply observed. Okay, whereas the tumors that were ERCC1 negative are the ones that got the standard adjuvant treatment. And this was a small study. It was only 150 patients. It wasn't intended to show a superior outcome, but what it did show was that actually they were able to characterize these tumors genetically in order to be able to start treatment within 2 months of surgery. Okay, so it is feasible. We don't have to use up months and months of time in order to acquire this data. However, we do need to have reliable tests to look for these mutations and these changes. And one of the reasons why they failed to go on to a phase 3 expansion of this trial was that they discovered that the ERCC1 immunohistochemistry, which they were using, was not reliable. And the results they were getting were at odds with previously published data. So that illustrates some of the challenges we face. The other challenge, of course, is that we are treating an aging population of patients with lung cancer, and therefore we need to think about the risk-benefit ratio in older patients. What you tend to find in the medical literature is that very often older patients will still benefit from chemotherapy, they will still benefit from biological treatments to the same degree that younger patients do. Okay, they get the same response rates, the same improvements in progression-free and overall survival. But they get more toxicity, and therefore we have to be careful with our dosing, and we have to be careful to support them through their treatment. So finally, we can see here the improvements in median survival that have taken place in systemic therapy of metastatic non-small cell lung cancer, and you can see how it's taken us 4 decades, if you like, to make that jump from a median survival of about 4 months to 12 months. And of course, the frontier is now that we take this even further and we make an even bigger jump. But we have to jump over the hurdles, including the funding hurdles that we are facing with our expensive new interventions. And this is the situation in the UK at the moment, where you have various funding bodies that are providing us with drugs. If drugs get approved by NICE, then it's reasonably straightforward, but if they're not approved by NICE, we have to apply to the Cancer Drugs Fund. If they're not on the Cancer Drugs Fund list, patients might be able to top up if they have private insurance. Okay. If drugs have not yet been registered, we now have this new scheme whereby we may get early access to medicines which are not yet licensed if they show quite significant promise. Okay, and drug companies will hopefully engage with this, and they will be able to provide us with drug free of charge, if you like, until that drug is registered. And there is already one drug which has been taken up by this program, a drug called pembrolizumab, which is being used in melanoma. But we need to make sure that these funding hurdles do not prevent us from, or delay us from being able to offer our patients cutting-edge technology, because they already have enough to cope with. And that is my final slide. Thank you very much.